started right now, and I'll just welcome everyone to the Clinical Consultation Network. This is Tuesday, August the 6th today, and we've got a great lineup for you today in Leslie Carson, who works in one of our seating and positioning clinics, who has come to talk about a case for a fellow named Gil Wood. Now, that's a pseudonym, of course, but she is going to tell us all about Gil and the challenges and successes that she's had with him, or is it her?
It's a man. Mm-hmm.
It's a man. Okay, just wanted to make sure. And so we will get to that in just a moment. I wanted to make a few announcements just to remind everybody again. Hold on, that we have coming up on August 22nd the TNAD conference. And so no matter what profession you're in, this is a great conference for you to come to. NAD stands for the National Association for Dual Diagnosis. Although now it's just called, it really just goes by the name, and then they say it's a organization for people with co-occurring intellectual disability and mental health disorders, intellectual and developmental disabilities and mental health disorders. And so anyway, we've got a local chapter of that called TNAD. So the NAD is the national organization. We have a local chapter called TNAD, and TNAD is having the 2019 conference on August 22nd, 2019. It's going to be at the Willis Conference Center at 26th Century Boulevard in Nashville. And the theme of this year's conference is Making My House a Home, Empowering Independence. And so we're going to have a lot of presentations about technology, ways that we can help people be more independent by the use of technology, and particularly helping them be more independent when they face challenges involved with mental health disorders. And so that is going to be the basic theme. Thane Dykstra, Dr. Thane Dykstra is going to be our keynote speaker, and he is a really great speaker, and he's going to talk about how to intervene with different sorts of behavioral challenges that you may experience. So I think it's going to be a great conference. Again, if you're part of the Clinical Consultation Network, you want to be part of this, and the response this year has been overwhelming. I think somehow, through everything that has happened, TNAD has finally started to take hold, and people are really responding well. We have just a high number of people who have registered for the conference right now. I think it's somewhere up around 75 or 80 paid participants. Then we have probably another 20 or 25 people who are attending because they're presenters. And so we just have a really great conference on tap. I know we're going to get probably even more people coming in the next few days and leading up to the conference. So highly encourage you to come to that conference. A couple other things I want to make you aware of. There's a lot of resources, out on the state websites. I was just scrolling through, and, I was wondering about whether everybody had access to information to put in their crisis plan and knew who to reach out to, maybe to get some collaboration on the crisis plan and to make sure that whatever you're planning for the person that you support, that Mobile Crisis is on the same page with you. And so I went to this Department of Mental Health Substance Abuse website and scrolled down here to, or went to their Mobile Crisis Services page there, and it has every mobile crisis unit listed throughout the state. So this is a heck of a resource, really. Whenever you put together a crisis plan, one of the things you should do right off the get-go, and as soon as you complete a draft of that plan, is to contact the Mobile Crisis Unit close to there to see if they have any suggestions or ideas about how you might modify that, or how you might, how you might make it more workable. Because a lot of what a crisis plan is all about is not just about working with the person, that's important, but also trying to arrange the system so that when something comes up, when something inevitably comes up, that you have a backup plan that you know what you're going to do in those circumstances. And a big piece of that is collaborating with these mobile crisis units so that you can get that information out there to them. Now, if you're going to share information and it's not in the midst of a crisis, you do need to get consent before you do that. So I don't want you to just send it on over to them without first getting that consent. But, once you get that consent, I advise you highly to begin working with the mobile crisis units to establish that relationship, but also to get their input and advice on how to approach the situation. I was also going to remind people about Project Transition. Project Transition is an agency that is there to help with these types of situations where a person is having frequent crisis. And they have a web page here where you can make referrals to them if you have someone who has been in crisis frequently. I think I was reading here that you do have to have had 2 or more crisis events within the past 180 days. But if you have somebody who meets that condition, I highly recommend that you would engage them in this process and get them to help you with the types of relationships that I was just talking about.
Hey, Bruce, we can't see your browser, just so you know.
Okay, well, Michelle, you got to break in a little quicker. So you can't see it. You didn't see anything I brought up?
In my defense, I did try to send you a chat message about it.
Okay. That's okay. All right, so let me go back to where I'm sharing my browser. Okay, there was the TNAD conference. There is the page on mobile crisis services, and I will distribute that link to people so that you can have that information and know how to get in touch with your local mobile crisis center. Here is the page on systems of support, so I am going to distribute that to you as well. And also, here's the clinical services web page, and I just want to remind you that all of the Clinical Consultation Network recordings that we do each week are included here. And so if you come to this link, you will find that we have the Consultation Network recordings for behavioral and psychological services, crisis and forensic, nursing therapy, all of those different disciplines. You'll find several presentations under each. I think right now we've got 11 recordings on here, and each week we're adding another one, and we'll add this one that we're going to do today. And so for today, I'm so happy to have with us Leslie Carson, who works in the Seating and Positioning Clinic, and she is going to present a case to us today of someone who has come through the clinic and that they have been working at helping. And so, Leslie, it's so good to have you here today, and I wonder if we could start out just by having you tell us a little bit about yourself.
Sure. Well, thank you for having me. I've been a physical therapist for 35 years as of this month, and I've worked in all the settings you can think of: home health, hospitals, rehab, outpatient. But my favorite settings have always been with people with developmental disabilities, and I've worked across this campus in various places. I worked at Harold Jordan Center for a few years, and I worked with the Middle Tennessee Homes before they were Middle Tennessee Homes, and then Debbie took me in over here. I did a little time with regional office, so I've worked on this campus in various places, and I'm thrilled to be here. What Debbie's built has been great, and I'm glad I get to participate.
Have you always been a Tennessean?
No, I was born in Georgia, and then my husband had jobs in different places in the country, so we lived in Texas for a while, and Missouri, and South Carolina, and now here.
Oh, okay. Well, I'm a Georgia boy myself, so I guess I came from Lithonia, Georgia, a little bit east of Atlanta.
I'm from Georgia too.
I didn't know that. And so
yes.
That's my co-host weighing in. That's Debbie Poyer. And I'm finally starting to pronounce your name correctly, according to the way you pronounce it, instead of mispronouncing your name all the time, Debbie. So, but it's good to have you on here today as my co-host as well. But you're from Georgia too.
Yeah.
What part of Georgia? Where?
Albany, Georgia.
Albany. I thought that was pronounced Albany.
It is if you're from Albany.
I know a guy from Pavo, Georgia.
Oh.
We'll have to have this conversation at a different time, but so yeah, we've got some connections here we need to talk about.
Yeah.
But I will say there was one great person from Pavo, Georgia, which is very near Albany, and his name was Cleve Dean. He was the world champion arm wrestler.
Oh.
And he was from Pavo, Georgia. Yeah. We went through there recently and saw his home place. It was pretty cool. But anyway, okay, so I digress. So thank you for that introduction. I'm proud to find out you're a fellow Georgian. Although I'm proud to be a Tennessean now too. I'm really happy to be where I am. But tell us a little bit about this case that you have. Gil Wood.
Yes. So Mr. Wood is 74, and until recently he was fully independent in moving his wheelchair around with his arms. He's a chatterbox. He enjoys joking around. He'd like to be more independent, and he's very social. As I go through this, I'm going to just know that this presentation I developed prior to a conversation I had yesterday. So I'll update you at the end with his most recent status. His diagnoses are he has paralytic syndrome, congenital deformity of the spine, scoliosis, cerebral palsy, abnormal posture, post-encephalitis syndrome, seizure disorder, and multiple visual issues, retinitis pigmentosa, macular degeneration, and several others. He has GERD and constipation, and he has arrhythmia nodosium, which is just swelling and bumps underneath the skin. He's, as I said, he's 74. He has intellectual disabilities, neurologic diagnosis, and
Hey, Leslie, I might have to do this a couple times. So, could you back up those first couple of diagnoses that you said? I think most people probably caught everything, but maybe those first two that you read off. Can you tell us a little bit more about those two?
yes,
I can't remember exactly what they were at the moment.
paralytic syndrome, and the second one is scoliosis. So he also has a diagnosis of cerebral palsy, which I think supersedes everything else, but it was the physician just listed it third as opposed to first. So he has issues with his muscle tone that don't really fit just cerebral palsy. It's also maybe an inconsistent movement that fits in under the paralytic syndrome, I think.
Okay.
And then the scoliosis, he has some scoliosis that's a little bit flexible, but the vast majority of it is a fixed deformity, a rigid deformity.
Okay. So you said the cerebral palsy kind of is the overarching diagnosis here for him, and so explain that a little bit. How does that take priority with respect to his diagnosis?
Well, and I'm speaking from my perspective, obviously.
Sure, of course.
It's from birth, and it defines everything else about how the body works because it's from birth. And oftentimes we hear that it may even be in utero. So I guess the jury's still out medically on that. But for him, it's primary to me because of how it affects his muscle tone, how it probably interacted with causing the scoliosis, or at least impacting it, how he moves, everything about how he moves in the world is affected by that cerebral palsy diagnosis.
Okay. That's very helpful. Thank you.
Sure. So the other he recently had a decline. He had severe medical issues that started in the fall of 2018, and then after that he had surgery for a gallbladder in February of 2019. And after that, he lost a lot of skills and was unable to transfer, and he couldn't bear weight, and he still had the swelling that began before that. The last time we saw him was in May. Due to Medicare guidelines, the feeding clinic cannot and does not see Gil at the same time that he's being seen by home health PT, and he needed home health PT also to recover from the surgery. He lives with others in an agency-supported home. It's accessible for his wheelchair. He has he has limited range of motion and poor coordination. He has good.
Leslie,
sorry.
You dropped out just a little bit right there. If you can repeat what you just said in the last sentence that you said.
Sure. Let's see. That he lives with others in the agency home. Is that where I should pick up? And it's accessible for using his wheelchair. He has abnormal muscle tone, which also limits the range for the amount of movement he has in his hips and his arms, and he has poor coordination, so he can't really, he's not very accurate with his movement. He does have really good long-term memory, but his caregivers report that in the last year or so, his short-term memory has decreased. He's always been very active in the home until recent medical issues caused a loss of his function during the day, his things that he can do himself, his ADL. He is very alert, and he assisted throughout the clinic with problem solving about his own care and what he wants for his own mobility. He's completely dependent on his caregivers at this time.
Hey, Leslie, tell me a little bit about how does he communicate? So is he verbal, vocal with you?
Yes, both. He's verbal, and he has a clear speech pattern. He's full sentences, and interacts really well with his caregivers. Some of his family members came and with me, so he interacted the entire time.
Okay. And how long ago had he had the surgeries that you were talking about? I think you said he had his gallbladder removed.
Yes.
Did you mention another surgery as well?
Yes. So in February, I'm not sure which came first. Either his gallbladder ruptured or there was a liver abscess. And I don't know which one happened first, but he did have gallbladder surgery after that. And
okay.
then
he was in February?
Yes, it was in February.
Okay. Thank you for that.
Sure. And then after that, he went into rehab. Gil, his family, and his caregivers report that his hands started swelling in the fall of 2018, and they remained swollen, and his medical team has been unable to completely diagnose that or completely treat it. There have been lots of attempts to reduce the swelling, but they haven't been completely effective. He also has generalized weakness, and at the initial visit, he was unable to weight bear through his legs for his transfers, and that was also a huge decline for him. Do you want me to go ahead with the current concern?
You know, you got to remember that you're on mute sometimes. Hang on just a second. Let me just check in with my co-host over here, Debbie Poyer.
We're not on mute.
I was. That's what I was saying, is I was on mute. So that's why I was a little bit of a pause before I came on. But I was just going to check in with you to see if you had any things you wanted to add at this juncture.
No, I think if she goes on with the current concerns, I think that would be good.
All right, excellent. Proceed, Leslie.
Okay, thank you. He entered the rehab center, and he stayed there 3 weeks. And because he lost his ability to walk and stand and transfer, that impacted everything else. And that also occurred around the hospitalization. He still has significant edema in his hands and feet, and he's had a steady loss of all his functional skills. Medical follow-up continues for treatment of his hands and feet, and we need a prognosis for the swelling of his hands and feet. That will help determine how we can help him with the wheelchair. Independence is very important to him, and because he's lost the ability to use his hands, we also thought about a power wheelchair, and he had used one in the past. So we introduced that concept to him, but there were also limitations in that way. His home has narrow doorways and a narrow hallway, and so we can't go any wider with seating than what he currently has.
Let me ask a question here, because this seems to come up, especially a lot of times, and you're not suggesting that he has a dementia condition, but he definitely has a circumstance that has sort of changed what's normal for him. And it's it sounds like it's more of a physical decline at this juncture than it is a cognitive decline. Would that be accurate to say, or am I misunderstanding? Okay.
Yes.
And so he's having this decline, and the question that I want to ask you as a clinician, particularly, when you're working with a situation like this where a person's starting to lose skills, lose physical skills, how do you balance the idea of helping this person get back to normal versus adapting to a new normal?
Well, you're right.
Is that a valid kind of? So how do you come to that as an occupational therapist? How do you come to that conclusion?
Well, you're right. That's what we try to do often. The balance is in supporting the person where they are, so that hopefully they can get a little stronger and maintain the abilities that they have. But you're right. We don't want to give so much intervention that we inhibit returning strength that might show up. And that's exactly what's going on here with Gil. We didn't want to go too far with our intervention and then discover in 3 months that he really didn't need quite that much and actually would like to have less intervention. So we've been in this kind of waiting mode. Go ahead.
It seems like a very common clinical theme, that comes up across disciplines, actually. Because certainly if you're looking at a person who's having a cognitive decline, and a lot of times this is an adaptation, I think, particularly families have a really hard time with, is adapting to a new normal, because they're thinking that your aim as the clinician is you're going to get them back like they were before, right? Mm-hmm. Where, what you're now doing is trying to figure out how can we make the best of it given the new normal condition that we have.
Exactly, right.
And that happens, you may sometimes have a 21-year-old who develops a psychotic disorder, as an example. And, the parent is thinking, we're going to cure this psychotic disorder. We're going to get them back to the kid, the young person that they were before. But in fact, what you're having to do now is react to the fact that you've got a psychotic disorder is occurring now, and it's got to be a new normal. I find that particularly families, staff, who have been with a person for a long time, sometimes have a hard time adapting to that, and also figuring out where they are in that process. Which are we trying to accomplish? And so I assume that's kind of the difficulty that you're having with this case, is figuring out where that dividing line is.
Yes. And then the other thing that's going on with him, because so much of this is physical, we almost have to address the physical needs. Like he's at much higher risk for skin breakdown and skin injury, so we don't want to let that go by the wayside while we're trying to preserve his ability to move the wheelchair. So in this situation, he's got a typical little wheelchair. He can move it with his hands on both sides. But if we were to go to a tilting-space wheelchair, it's a heavier chair. It would tilt back, but it'll be too heavy for him to move by himself, typically. So that's also why we looked at power, because we thought, well, he could still have independence, and it would challenge him in new ways. And at the same time, we could get a chair that tilts and release pressure, but it also allows him to interact with his world maybe in a equally good way.
But the problem with power is it doesn't really fit in his home, correct?
Right. And so the next thing that came up, which is also why Gill's complex, is that there's been discussion on him moving to a different house. So his options open up if he has a house that's a little easier to get around and is more accessible. And it would also possibly change if he changed agency. So there are multiple things going on with him. There's all the medical issues as well as his environmental issues. And like you've mentioned before, it's just trying to find that balance.
Yeah, you're right. I think it is a balance because, you know, and I'll just, I'll share a quick personal story of when my mother now, and again, I'm not saying that he has dementia because it doesn't sound like there's a cognitive decline again. So I'm just using this as a little bit of an analogy. My mother had severe dementia. When she moved to a new location, her condition worsened.
Yeah.
Because it was such a transition for her, and it was so different from the home that she had been in for many, many, many years. And her relationships with other people changed significantly at that point. And so, you know, I think that's always a consideration whenever you're talking about moving someone is what are the risks and benefits of making this change. And, you know, I do see where you're coming at this from the perspective of, well, you know, if he's able to move more freely, if he's able to regain some independence here, that's going to be helpful to him. And so I guess, you know, in some manner it's a matter of balancing that a little bit and considering the risks of him moving out of that setting as well, especially if we were to change agencies. Because now I don't know to what extent he has extended relationships in this agency or to what extent they may be able to kind of move along with him, but you know, I think that would be a factor to consider as well.
Absolutely.
Yeah.
The other thing I wanted to mention is that his weight now is about 140 pounds, but he's lost about 30 pounds because of all the medical issues he's had going on. So we saw him in clinic and did our evaluation, and we do simulations and we look at different types of equipment because we try to start with commercial products, which means it's something that the insurance can fund and can be bought off the shelf or certain sizes. But first,
before we leave the issue of the weight loss, let me ask this about that. Has his appetite changed over this course of time, or has he been losing weight for some other unexplained reason or some other reason?
My understanding is that he lost weight directly related to the problem with his gallbladder and his liver abscess, and just he was unable to tolerate a lot of different foods. But the last time that I saw him, his appetite was returning, and he was doing better that way.
So this might have been sort of a temporary reaction to the surgeries that he had, and maybe that's coming back. But there seems to be a real critical variable to keep an eye on in this situation.
Right. I think it contributed a lot to his loss of strength and his loss of endurance and all of those types of things. And I just want to mention one other thing that we also look at is oftentimes people don't want to a group might not want to consider going from a manual push chair to a power wheelchair because they think that the person loses an opportunity for exercise. But oftentimes we look at a lot of things, and in his case we would look at age and his recent medical issues and think, well, it's more important to preserve his energy throughout the day as opposed to just for moving that wheelchair through the house. So that's also a trade-off that we could look at. If we were actually able to provide him with a power chair, then he could preserve and use his energy for things that really matter. Like he would be able to maybe eat better and eat longer because he wouldn't be so tired at the end of the meal, particularly evening meals.
Let me say something about this, because the several cases that we've had as it relates to occupational therapy and all of the therapies, physical therapy and so on, and those coming from seating and positioning clinic, your consideration of that variable that you were just talking about, a person's physical ability, their energy level throughout the day, this has become so ubiquitous really through a lot of different areas. I'm thinking because I'm a baseball fan, and one thing that they look at nowadays about pitching is, how many pitches have you pitched? How much of what your reserve have you expended? In the old days we used to say, just power through, You're gonna pitch 9 innings, you're gonna pitch a complete game and all this. And there's much more attention paid not only to within a game how much a pitcher pitches, but how much they pitch across the whole season and what that means for the postseason. And it seems to me that you guys in the seating and positioning clinic have kind of mastered thought on this topic for the people that you're serving. That you're thinking about what's the best way for them to expend this energy?
Yes.
Whatever reserve that is. And being sensitive to the fact that he's 74 now, right?
Mm-hmm.
So he's not
right.
the same person that he might have been at a younger age. So how much are you going to try to move him or press him to engage?
That's a really good point.
That's exactly right. I mean, and like you were saying, I often use my own personal experiences for this too, because at the age I'm at now, I understand that I just want to accommodate to what I can do. It doesn't expect me to change. My body's not going to change a lot, but for better, probably.
I like the word you use there, because it is sort of you go back to Piaget's theory of development. Sometimes you're assimilating old things that you did. Sometimes you're accommodating to the new circumstances. And, that is, I think, part and parcel of the decision that a clinician, any clinician, is always trying to make.
Yeah. Yeah. True. So I thought I would just finish this up by kind of giving you a kind of summary of what we ended up doing. He came to us, we had 3 visits with him, and we did the trial of different equipment. We also gave him loaner equipment to improve his current wheelchair and did some custom things, did some different positioning techniques for him, gave him some things to try because we didn't want to choose, let the family and him choose a chair right now at this critical stage because it could go either way. And in this insurance world that we're in Medicare, you can't get more than 1 chair in 5 years unless something dramatically changes. So we are fortunate to be able to use equipment that comes back to us and repurpose that for someone else so that they can try and find out what really works for them and in their setting. So the last time we saw him, we finished up those types of things and gave him a different seat cushion, gave him more support for his back, a different lap tray, that sort of thing, all those things to give him the more support that he needed now because his trunk he's so much more, he's leaning a little bit more than he was before. So we sent him away and he started seeing his physical therapist again at home. And I did do follow-up yesterday because I thought we would be able to get him back in by now, but unfortunately, he did improve a little bit, but then he had a decline, and he was in the hospital again last week and has just been diagnosed with blood disorder. And we believe it was leukemia, but we don't know that specifically. So at this stage that we're in, we're back in a holding pattern because they're going to try to get him stable, and as we all know, it could be that he does rally, and in that case, then we'll see him back in clinic and get him taken care of, and we may switch to a Loner Tilton space chair. We'll just see how it all plays out, but this is what we do for this population that we serve, like all of you have been talking about.
It's amazing how complex these cases get, and we're always, I think, humans in general are always trying to get back to, okay, what's the cause of this? What's the thing that's causing this? And then what you end up facing so many times in the cases that we work with frequently is that it's not just the one thing. I go back, I hope I haven't used this analogy too much with people, but there was an old movie called City Slickers.
Yeah.
In that movie, there was a ranch hand named Curly, and Billy Crystal, I can't remember his name in the movie, but he asked Curly, "What's the secret to life?" And
Jack
Palance, who's playing Curly, held up one finger. He said, "One. What's the one thing? What's the one thing?" Well, you got to figure out what that is. I think in clinical work, we think too much sometimes about the one thing because there are lots of things that make these situations that we deal with, particularly, very complex cases that we're working with here, where a person, okay, so you can build a timeline here, and you can say, okay, it started. We started to see some changes at the point that he had these couple of surgeries that he had, and there has been some change, and then there starts to be some recovery from that, and then another complicating factor steps in, and somehow now, as a flexibly thinking clinician, you've got to weave that into your projections about what's going to happen here and what the best way to approach this situation are. One of the things I love about everything that you said is how much you are taking his goals into account, though. And so, I was thinking about this because, depending on who you are, how you were raised, and these types of things, you might say, oh, well, the thing we need to do is keep pressing with him, keep him going. Don't let him decline. And then other people might say, well, maybe we need to accommodate more for him. We need to really try to take care of him. And generally speaking, the truth lies somewhere in between those as to, what the optimal or best approach to it is. And I think we're constantly trying to sort those things out as we work with people.
Yeah.
So I have spoken a lot here. I'm going to open it up to my co-host just for a second, see if she has any additional commentary about what we've heard today.
No, I think Leslie did a great job with what she presented. So I think this is awesome. And I think she's doing a lot to think through the process and figure out what's best for this gentleman, which is important.
Yeah, I think, again, this is why I think it's good for so many different types of clinicians to listen in on this, because I think that we all face these same sorts of dilemmas each day that we're working with people. And so with that, I will open it up to the group on the phone and just see if we have any additional questions or commentary for Leslie. Well, okay. So if there are no questions, I guess I'm going to wrap it up here. Again, Leslie, I want to thank you so much for your presentation today and for bringing this case to us. and kind of explain a little bit of your thought process as you work with this really difficult case. I hope I wasn't too hard on you today.
Oh, well, thank you. I enjoyed it, and I'll look forward to listening to
Yeah, how do I get her included? Can I just forward it to her so she can start sitting in on these, or?
You can forward this. You can forward this to her, but also send your email address to Michelle Bagby, michelle.bagby@tn.gov, and ask her to add you to the mailing list so that you will get my wonderful communications each week, and you can be reminded that we're doing this each day, and that we want to have you on the mailing list as we do anybody out there who's interested in participating. And as I've said many times before, Clinical Consultation Network is something that is available for everybody. See, I think that even person-supported can benefit from listening in on our conversations here.
Absolutely.
If we're able to kind of break it down here so people understand what we're talking about, the more people can understand about their own health care, the better participants they are in their, taking care of themselves. And I think that also applies to direct support professionals, to administrators, to program managers, many different people throughout our system, as well as clinicians from all different stripes. So please invite people far and wide to participate in these sessions. And just remember that this is the Clinical Consultation Network. I also want you to remember, if you have a case that you'd like to present on one of these sessions, please let me know about it, or let any of the clinicians that work in the Clinical Services Division know about it, and we will get you on the agenda. We want to hear from you, and we want to discuss your case. And if you have particular things that you're trying to figure out on a case, particular questions, we'll try to answer those questions. We appreciate all different kinds of situations that people may be facing, big, small, severe, difficult, or relatively easy situations and success stories. We like all of them. So please get in touch with us if you want to do that. I want to remind everybody again about the TNMED conference coming up on August 22nd. And so that is going to be a great conference, as I said before. And so please stay in touch with us, and we will see you again next week, 30 p.m. Central Time, for the Clinical Consultation Network. Thank you so much for being here.
Thank you.
Thanks, Bruce.